Now, vomiting involves two function distinct medullary centers. They are located, we call the vomiting centers and the chemoreceptor trigger zone. The act of vomiting is thought to be a reflex that is integrated in the vomiting centers of my medulla, which is located in the dorsal portion of the reticular formation of the medulla near the sensory nucleus of the vagus. Vagus is the 10th cranial nerve, and the vagus nerve is stimulated because of the vomiting centers. Reticular formation of the medulla is stimulated. Now, the chemoreceptor trigger zones is located in a small area on the floor of the fourth ventricle, where it is exposed to both the blood and the CSF chemicals in the blood and my CSF fluid, where the chemoreceptor trigger zones are exposed, and is thought to mediate the emetic effect of blood, bone, drug, and toxin. Important. Swallowing have different, if you look at that one, swallowing is, first of all, it is a mechanism depends on coordinated actions of tongue and the pharynx. We call swallowing reflex, if you folks remember. Swallowing reflex, the first part of the swallowing is 100% voluntary. The second and third part is 100% involuntary. Please remember. The first part, which is voluntary, which is done with the help of tongue. And then later on, the pharynx and esophagus takes over as a part of reflex, which we don't have to think about. We do have swallowing reflex in the medulla. And all these structures which are taking part in the swallowing are innervated by the trigeminal nerve, which is my fifth cranial nerve, the ninth cranial nerve, which is glossopharyngeal, 10th is vagus, and the 12th is 12th cranial nerve. 12th cranial nerve. Hypoglossal. And that hypoglossal nerve innervate what?
The tongue.
Tongue. Hypoglossal is a motor nerve which innervate my tongue muscles. Tongue muscle is 100% skeletal, it's 100% voluntary. That's what I said. Swallowing, first part of swallowing is 100% voluntary. Please, is already highlighted. It says alteration in the swallowing mechanism, alteration in this esophagus. Number one is dysphagia. Dysphagia is difficulty, the term called difficulty in swallowing. Number two, odynophagia. Odynophagia is because of some inflammation within the esophagus. The patient complain of painful swallow. That is called odynophagia. Patients sometimes complain of failure of esophageal sphincter to relax, and that causes a difficulty in the passage of food from the esophagus into the stomach. That's called achalasia. Please remember, all these are bold and are important. Now, which of the following does not involve an alteration in the esophagus or swallowing? Look at all those three which we already discussed. Yes. The last one is gastroesophageal reflux disease. It is a reflux mechanism where the content of the stomach, along with the juice, going back towards the esophagus because of the incompetent esophageal sphincters. So please remember, all except gastroesophageal reflux disease, which doesn't involve the esophagus. Now, please highlight what is gastroesophageal reflux disease. It refers to the backward movement of the gastric content. Please highlight everything. Gastroesophageal reflux refers to is a backward movement of the gastric content into the esophagus or beyond, or into the oral cavity or lung. Look at those, the content on the stomach going backward. And this condition causes, highlight, most common and painful complication of gastroesophageal reflux disease is the heartburn. Heartburn, also called pyrosis. Always sort of discomfort in the epigastric region causes heartburn. Heartburn itself is most common and painful complication of my gastroesophageal reflux disease. We already mentioned about the dysphagia. Dysphagia produces a narrowing of the esophagus and difficulty in swallowing. Dysphagia. Make it more, which is already from the previous slide. Or dinophagia is a pain on swallowing of food, even the liquid, and may be associated with disorders of the esophagus, any inflammation in the esophagus that causes odynophagia. Achalasia occurs when the lower esophageal, when LES, lower esophageal sphincters, fails to relax due to disruption in the input from the enteric neuroplexus and the vagus nerve. So lower esophageal sphincter is supposed to relax. And that lower esophageal sphincter is not relaxing. That's why I'm having trouble in passing my food from the esophagus into the stomach. Now, we are talking about the gastroesophageal reflux disease itself. I already said about the heartburn. Make a highlight. Now, this heartburn usually causes within 30 to 60 minutes after a meal. Usually, most of the complaint patients said evening time. Pain in the epigastric region. Make a note, in the epigastric region. Sometimes they radiate to the throat or in the shoulder or the back. Now, we can avoid this reflux disease, avoiding large meal. Number 2, alcohol. Number 3, smoking. Eating meals and sitting up. Next, avoiding recumbent position several hours after a meal. That is the important also. Avoiding bending for long periods of time. We can get little benefit during sleep if we raise our head. Sleeping with head elevated. Sometimes the head end of the bed, if elevated, that also helps. And also, if we are overweight, we have to lose the weight. And above all, stress. Now, complaints accompanying esophageal diverticulum. Diverticulum is, the word diverticulum is a condition where a tube, all of a sudden, they bulge and then become tube again. And this, the word diverticulum we call is a Waysid. WAYSID, Waysid. And that is my diverticulum. The food stops before it reaches the stomach. Patient complains of gurgling, belching, coughing, and most important is foul smelling breath. Patient with diverticulum, all this, especially the foul smelling breath is the important. Patient with esophageal diverticulum. Important right now, esophageal cancers. Most common cause of esophageal cancer is the smoke. Number 2, alcohol. And they cause squamous cell carcinoma. Now we do have adenocarcinoma where the squamous cell is replaced by columnar cell. Please remember, in Barrett esophagus, normal lining of the esophagus, which is squamous type, is replaced by the columnar cell. And that is called Barrett esophagus, and that gives me a sign that something is not okay. Adenocarcinoma. That is a cancerous condition. Barrett's esophagus, highlight. Now, patients have dysphagia with esophageal cancer. They have history of, they are losing weight, no appetite, anorexia, fatigue, painful swelling, or dinophagia, and not easily caught. So please remember, we do suffer from esophageal cancer. Esophageal cancers, patient with tobacco smoke, and also the alcohol. Sometimes the cell changes, and that I discuss under what? Cell changes under what condition? Barrett esophagus, where the squamous cell is replaced by columnar cells. Now, factors contributing to the protection of the gastric mucosa. Please remember, because stomach is only organ which faces with highly acidic environment. We call hydrochloric acid. So stomach need extra protection. Now, gastric mucosal barrier, which is impermeable, and impermeable epithelial cell surface covering. Mechanism for selective transport of hydrogen and bicarbonates, and they have a characteristic of gastric mucus. Now, one is water insoluble, and the other one is water soluble. Let me go back. Water insoluble mucus. Please remember, these water insoluble mucus forms a thin, stable gel that adheres to the gastric mucosal surface. These mucus are protecting the cell lining of my stomach. Provides protection from what? From enzyme, a protein digestive enzyme we call pepsin. And also make a note over there, hydrochloric acid. Not only pepsin, also hydrochloric acid. And hydrochloric acid is produced by one of the cells in the gastric gland. What is that called? The cell which produces hydrochloric acid in the stomach. What is the name of that cell? Come on, folks. Name the cell which secretes hydrochloric acid in the stomach.
Parietal cell.
Parietal cell, yes, parietal cell. We do have different types of cells in the gastric gland. Parietal cell secretes my hydrochloric acid and also intrinsic factor. Okay, good. So remember hydrochloric acid and remember pepsin. They form an unstirred layer that traps bicarbonate, forming an alkaline interface between the luminal content of the stomach and its mucosal surface. Bicarbonate is also protecting the mucosal surface of the stomach. Now, water-soluble mucus wash from the mucosal surface. and mixes with the luminal content. That's how they are, even though water soluble, they do have a protective function. They wash from the mucosal surface, please remember, and mixes with the luminal content. What is luminal content? I didn't get it. What is luminal content? Anybody? Luminal content. It is the material, my food, my gastric juice, all those secretions within the stomach. That is my luminal content. It mixes that mucus, water-soluble mucus, mixes with the luminal content. As a result, its viscid nature of the mucus makes it lubricant that prevent mechanical damage of the mucosal surface. Even though this mucus, which is water soluble, still they do have a protective function. Okay. Major causes of gastric irritation and ulcer formation. Please highlight. Very common medicine we call aspirin, and it is one of the medicine to prevent heart attack also. And also not only prevent heart attack, aspirin not only prevent heart attack, and also prevent some cancers. Aspirin. And somebody is allergic to or cause irritation with the aspirin, they can take, we call baby aspirin. What is the dose? How much?
81 milligrams.
81 milligram. 81 milligram of baby aspirin. And that aspirin tablet is coated with a chemical we call anticoated. Is not going to irritate my gastric mucosa. So now let's talk about the aspirin or other known steroidal anti-inflammatory drug like ibuprofen, Advil. Irritate the gastric mucosa and highlight in what it does. Aspirin inhibit my prostaglandin synthesis. Prostaglandin synthesis. It irritates my gastric mucosa. Also, on the other hand, it inhibits prostaglandin synthesis. That's why we do take aspirin, regular aspirin, which is 325 milligram. Regular strength is 325. We do take aspirin for pain. And the cause of pain is due to prostaglandin secretion. I'm having pain in my body right now because of prostaglandin secretion is going on. If we take aspirin, this aspirin, which is regular aspirin, is 325 milligrams, inhibit the production of prostaglandin. That's why we got relief from pain. Is it clear? But so it is very important. So if somebody has taking aspirin or any painkiller, they might suffer from gastric irritation, and that might lead to ulcer formation. The most important cause of gastric irritation, ulcer formation is H. pylori, infection by Helicobacter. We call H. pylori, Helicobacter pylori. It's a bacteria which causes gastric ulcer. Please remember. What it does, this bacteria, H. pylori, it thrives in an acidic environment of the stomach. They're okay with the acidic environment. That's why they thrive over there and they cause ulceration. Now, what it does, it disrupt this H. pylori, disrupt the mucosal barrier that protect my stomach from harmful effect of its digestive enzyme. So please remember the most common cause for gastric ulcer is, most common cause of gastric ulcer is
H. pylori.
H. pylori. Please remember.
I have a question.
Yes.
Doesn't H. pylori actually try to make a like less acidic environment so they could actually thrive?
Can you repeat again the last part?
Don't they try to make the stomach a less acidic environment so they could actually thrive?
Yes, the reason is this bacteria doesn't thrive in the lower part in the alkaline media. This bacteria, in order to thrive, they need an acidic environment. And that's why it thrives over there.
Okay.
And now I'm taking all different types of medication to stop my gastric ulcer. I'm taking antacids and other medication to neutralize my acid, but I'm not killing my bacteria. Is it clear?
Okay. Yeah. Yes. Thank you.
Now, we do have gastritis, which is inflammation of the gastric mucosa of the stomach, in the acute form, please remember, and chronic form. Acute is a transient inflammation of the gastric mucosa that's called acute gastritis. What are the cause? Most commonly associated with local irritant such as bacterial endotoxin, the chemical released by bacteria, aspirin, and alcohol. Now the chronic, characterized by absence of grossly invisible erosion and the presence of chronic inflammatory changes. The mucosa undergo changes, and that is the cause we call chronic gastritis. It's prolonged, leads eventually to atrophy. Please highlight what we see during chronic gastritis. The mucosa undergo atrophy, the glandular epithelium undergo atrophy. In some places, there are ulceration. In some places, the atrophy replaced by fibrous tissue. And that is my chronic gastritis. We already mentioned for chronic gastritis, the causative agent is Helicobacter pylori. Please highlight and remember. There are other causes like medication, the alcohol, and autoimmune, multifocal atrophic gastritis, some chemical gastropathy, which is I'm not worried. Please remember the most common causes right now, the bacteria, maybe my alcohol, maybe I'm taking medication. That might also cause chronic gastritis. Okay. Now, non-steroidal anti-inflammatory drugs and aspirin contributes to the formation of gastritis by inhibiting, we already said that one. Inhibiting what? Synthesis of prostaglandin. That's their aspirin is very cheap medication, very cheap but very useful. But we have to be very careful if it causing problem in the body. Sometimes the people who is taking aspirin, even baby aspirin, they do see on the skin some bruises. Even by taking baby aspirin. If somebody is having those bruises we never had before, but after taking aspirin for 6 weeks or a month, couple of months, they should stop taking aspirin, even it's baby aspirin. That will lead to, not only lead to gastric irritation, but also might lead to ulceration and other complications. I call those skin bruises for taking aspirin, I call it spousal abuse. Don't take it. To make it lighter, I call spousal abuse, all bruises in the body. But it is not due to spouse. Synthesis. Inhibit the synthesis of prostaglandin, that's what we said. The synthesis of prostaglandin is decreased. Please highlight the whole thing. Because of taking aspirin, the synthesis of prostaglandin is decreased due to anti-inflammatory action of my drug, which is my aspirin. And therefore, acid production is unregulated, and that causes irritation because of taking aspirin. We already said H. pylori colonize in the mucus secreting epithelial cells of the stomach. And this bacteria, H. pylori, produces an enzyme and toxin that have the capacity to interfere with the local protection of the gastric mucosa against the acid. And they produce intense inflammation. They might elicit an immune response. In order to diagnose the cause for gastric ulcer or gastric irritation or chronic gastritis, in order to confirm H. pylori, we test carbon urea breath test using radioactive carbon isotope. This is number one. Stool test for antigen, because this H. pylori, they do produce immune response. Number three, endoscopic biopsy for urease testing. They take the tissue from the stomach and do the biopsy. Blood test to obtain serologic titers. This is most common for H. pylori antibodies also. If it is positive, then the treatment regime is completely different, not only antacid. Okay. What is peptic ulcer? What is peptic ulcer? Anybody? Why not gastric ulcer? Why not duodenal ulcer? Why not esophageal ulcer? Why they call peptic ulcer? Because the ulcer over here, number one is the ulcer is taking place at multiple sites. Not only the stomach, might involve my duodenum, might involve my esophagus. When the ulcer involves or taking place at multiple sites, then we call peptic ulcer. Is it clear, folks? If it's only in the stomach, I will call gastric ulcer. If it's only the duodenum, I will call duodenal ulcer. If both, I need to change, I said peptic ulcer. Is it clear? What is the reason behind? And that's very common over the counter. Say peptic ulcer disease, tablet, take this tablet. Peptic ulcer. Okay, so peptic ulcer, it is an ulcerative disorder that occurs in the areas of the upper GI tract. I mentioned that one already. Upper GI tract. It might involve my esophagus, it might involve my stomach, it might involve my duodenum, which is the first part of the small intestine. That are exposed to acid pepsin secretion. Spontaneous remission and exacerbation are common causes. Again, look at the cause. H. pylori, aspirin, and common in age group with warfarin is a blood thinner that might also be predisposed to peptic ulcer, and also smoking and alcohol. Please highlight. Now we are talking about suffering from peptic ulcer for a long time. Now the complication of the peptic ulcer, this first complication over here we call gastric hemorrhage. Gastric hemorrhage, which is the bleeding. If, please make a note, if gastric ulcer, chronic gastric ulcer persists for long duration, might undergo perforation. What is perforation? Perforation means make a hole in the wall of the stomach. I was suffering from chronic gastric ulcer, that ulcer is now perforated, and because of the perforated gastric ulcer, now I'm suffering from gastric hemorrhage, bleeding. Very common. So acute, we call acute gastric hemorrhage is one of the complications of chronic peptic ulcer because of perforation. Everybody's okay with the perforation? I explain what is perforation is. If you see, don't get shocked. Okay. Now the number 2 complication is we call obstruction. Also we call outlet obstruction. Gastric outlet obstruction. Make a note. Gastric outlet obstruction. Because of the chronic gastric ulcer, look at that one, caused by edema. This obstruction is caused by edema, spasm, or contraction of the skull, tissue, and interference with the free passage of gastric content through the pylorus or adjacent areas. Gastric outlet obstruction needs surgery. Perforation, which is already said, is one of the complications also. Occurs when an ulcer erodes all the layers of the stomach, all the 4 layers of the stomach or duodenum. And everything what we have in the stomach right now within the peritoneal cavity. Severe pain, patient might go into shock. Emergency operation. Now gastrointestinal tract, we call coming outside from my mouth, we call hematemesis. Hematemesis, I noticed something blood stain in my vomit. That is hematemesis. Something is coming through my stool. That is melena. Hematemesis, when you're throwing up, if it's blood stain, it's called hematemesis. Blood in the vomitus, that is hematemesis, may be bright red or maybe coffee ground appear because of the blood is altered already, because of the enzyme in the stomach. The enzymes in the stomach altered my blood, turned from red, turning into coffee ground, a coffee color. Now the melena, please highlight and remember. Melena, it is the blood, first of all, it is the blood in my stool we call melena. And this melena ranges from bright red to tarry black color. Sometimes we don't see any blood, but we do have, in this stool, we do have blood. And that, please highlight, is we use a term called occult blood. Occult means hidden. Stool looks fine. But when they did a guac test, they found that test is positive. They said your stool contains some blood, which is blood was hidden, occult. Sometimes the obvious, which is might be bright, fresh blood, may be bright red. Altered blood is black stool, or black color. Now, in that case, you have to take the history of the patient. Are you taking any medication? If you're taking any medication, drug history, medication history is the important in these cases. Are you taking any iron tablet? Are you taking any aspirin or painkiller? Okay, now question of treatment. Okay. Treatment, eradicate the cause and promote a permanent cure for the disease. Now, eradicating H. pylori or relieving the ulcer symptoms, healing the ulcer crater by using acid neutralizing or acid inhibiting drugs and mucosal protectives. Using antacids, or we call using the drug we call PPI, proton pump inhibitor. Proton pump inhibitor, PPI, which let the stomach release its content. Now, the risk factors for the development of stress ulcer. Please highlight, it is already says stress ulcer. Now, this stress ulcer is the common in ICU, intensive care unit patient. They do suffer from stress ulcer. That's why they are given medication for them not to have that stress ulcer, because they are most like prone for stress ulcer in patient with ICU. Like what, if you look at that one, like trauma, patient with trauma, severe trauma, head injury, severe infection, sepsis, acute respiratory distress syndrome, severe liver failure, major surgical procedure. I went under major operation, major surgical procedures. And there's another condition over here is, please highlight, it's called Zollinger-Ellison syndrome. It is a Zollinger-Ellison syndrome where they produce a tumor within the stomach. Please remember, Zollinger-Ellison syndrome, during which patient produce a tumor within the stomach which produce gastrin. And that gastrin predisposes to ulcer formation. So patients in ICU are more prone for stress ulcer. So these are the causes for stress ulcer, like the trauma, the sepsis, major operations. Now, these are the risk factors for the development of gastric cancers. Some runs in family, some are carcinogenic factors in the diet, all those preservatives in the diet. Sometimes these are autoimmune. Sometimes, and that carcinoma, cancer, may be in the form of polyp or in the form of adenomas. All these conditions causing altered intestinal functions are important. Please remember right now, it's called irritable bowel syndrome. Number 2 is inflammatory bowel disease. Number 3 is diverticulitis. Next is appendicitis. Alteration in the bowel motility. Motility is what? What's motility? Movement. Now, next is malabsorption syndromes or cancers of the colon and rectum. Cancer of the colon and rectum, patient usually present with some bulge on the mucosal surface. And when we do digital rectal examination, we do feel that swelling we call polyp. Please remember, sometimes the patient notices something is coming out from the bottom, from the anus. That's polyp. And that polyp, when the doctor examined with finger into the rectum, we call digital rectal examination. They said, this is not the only one, you have multiple within. And then they said, we're going to perform sigmoidoscopy, colonoscopy to get the exact picture of what is going on inside. So colonoscopy, sigmoidoscopy are done to visualize inside the colon. Sigmoidoscopy will visualize only the sigmoid colon. Colonoscopy throughout the colon. So what they're doing for? They are looking for polyps. If they have polyp, they remove the polyp, do the biopsy, and get the report. If it's cancerous, then the treatment regime is changed. Is it clear? So please remember. Okay. Before I go into this part, next slide. I'm here again, the perforation. I was suffering from peptic ulcer. And in the middle of the night, the ulcer perforated. I felt severe abdominal pain. Rushed to the hospital. They did X-rays and everything, said you have perforation right now. We need to operate. They operate, they fix, they repair the perforation. And what the nursing staff did, I asked after my operation, can I have my water a little bit? They gave me water. That water or sips of water right after operation might cause obstruction. Look at this. They give me, because I asked them, because I was thirsty after operation. So we should not give those patients right after surgery any sips of water. They have the time. And provided, that's what we do after operation, we do check with the stethoscope, we do hear for the bowel sound. We do check for the bowel sound with the stethoscope. If you can hear the sound, you're okay to get it. And I'm going to ask you also, oh, did you pass gas? Did you pass gas? Patient will say yes. And then I will confirm with my stethoscope, I will hear those bowel sounds. Then you're okay to have some water gradually. Water, then liquid, then normal. So please remember, because the reason I pulled this one, that might cause, I give water, patient should not have water right after operation. Okay. Now also, I said about the obstruction. Everybody's okay with this one? Because I was doing favor with the patient because he asked me. But I should not. Now, and also, patient after any abdominal surgery, when they are in the bed, they are most likely to develop, make a note, most likely to develop intestinal obstruction. After any major surgery, I'm on the bed. My age, my operation, will most likely to cause intestinal obstruction. I'm a good candidate for intestinal obstruction. Okay. Now the infections. What's that? You guys want some break? Let's take a 10-minute break. 15-minute break. Right now 10:05 or 10:20 returning time. 10:20 is the returning time. It's a 15 minutes break. Go stretch out, relax, go have vitamin D, whatever you want. Folks on Zoom, we're going to have 15 minutes break. Returning time is 10:20.
Thank you, Professor.
I'm trying to do a study plan, but like not anything. I sent it to you. I'm working on it.
Alright, is it long? Is it long?
I did one page.
I know. I kind of
Okay. I know. I know. I texted her.
in person?
Pardon?
Our final? Is it in person?
Uh,
virtual?
I will let know
Okay.
if I hear something from, if there is change.
Okay.
It's supposed to be here, but depend on the sitting arrangement.
Okay.
I will let you folks know through my canvas.
Okay.
One. Okay, but so let's get back. Okay, the conditions causing altered intestinal functions, we said all these conditions are important. Number one, infections of the intestine, most common is viral, followed by bacterial. Rotavirus, all of a sudden, within half an hour, 2 hours, start throwing up rotavirus. And we do have bacterial infections in the form we call Clostridium difficile. Sometimes the patient's taking antibiotic, they do suffer from diarrhea. E. coli, also very common. Protozoal infection, we call E. histolytica. Now, please remember, these are the characteristics of irritable bowel disease. Number one, persistent or recurrent symptoms of abdominal pain. Altered bowel functions, constipation, diarrhea, pain, discomfort, the altered bowel functions. Varying complaints of flatulence, bloatedness, nausea, and anorexia. History of constipation or diarrhea. Patients have sometimes they give history of anxiety and depression. Now the Crohn's disease, please highlight as one of the conditions, falls under inflammatory bowel disease, we call Crohn's disease. It is a recurrent granulomatous type of inflammatory response. Highlight everything right now. It is Crohn's disease is a recurrent granulomatous type of inflammatory response that may affect any area of the GI tract. Start from the mouth to the anus, but most common site is in the small intestine, and they do produce skip, we call it skip lesion. Crohn's disease. And in the textbook on page 1091. Textbook page 1091, the age chart, a table, difference between the Crohn's disease and ulcerative colitis. Crohn's disease and ulcerative colitis, there's a table on page 1091 in the textbook. Please go over with that table also, that is important. Now, ulcerative colitis. What is ulcerative colitis? It is a non-specific inflammatory condition of the colon. And that ulcerative colitis usually involves the left side of the colon. Crohn's disease usually involves the right side of the colon with the small intestine. And the ulcerative colitis, which are more common on the left side of the colon. And with patient, please remember, with patient with ulcerative colitis, they may be mild, moderate, severe. In severe form, they give history of blood-stained stool. Passage of blood-stained stool 10 to 20 times per day. Look at the condition of the patient, 10 to 20 times passages blood-stained stool in patient with ulcerative colitis. Now, this is diverticulitis, symptoms of diverticulitis or diverticular disease, diverticulosis, pain in the left lower quadrant. Patient may complain of nausea and vomiting. And also, not only pain, when we touch that part of the body, we notice tenderness also. Patient, when we put our hand on that part, put a little bit pressure, patient facial expressions expresses that patient is not in comfort, pain. That is tenderness. Patient may have slight fever, may have elevated white blood cell count because of the inflammation. In order to prevent this condition, diverticulitis, person should encourage, they should have vegetables, high fiber diet, which will prevent the occurrence of diverticular disease. If the patient is only hate fibers, hate vegetables, they are more likely to develop this diverticular disease in later part of their life. So in order to prevent, we should have vegetables, the fruits, plenty of vegetables and fruits in our diet every day. Balanced diet. If somebody already developed diverticulitis, in that cases, they should not take those peanut. Peanut aggravate the condition. Now, the condition over here we call appendicitis. What is appendicitis? It is an appendix becomes inflamed. Please remember, it's important. Appendix become inflamed, swollen, and gangrenous. And it eventually, in some cases, in late cases, it perforates also, if not treated. I operate on one patient, age was 80 years old. He came after 10 days of appendicitis. He was getting treatment all over the peripheral part of the country. Then ultimately he ended up in the capital city and in my hospital after 10 days of appendicitis. I noticed on his right iliac fossa, a little bit swollen, very tender, very toxic. Patient was very toxic, and the mass was very tender. When I operated the patient, appendix was black. Almost 10 inches of the terminal ileum was black. Part of the ascending colon was black, all gangrenous. Patient was not supposed to survive. I cut part of the healthy part of the ileum and anastomosed with the ascending colon. The whole abdominal peritoneal cavity was full of fecal material and the pus. And the whole operation theater was full of fecal smell. My assistant said, "Can I leave?" Because he was throwing up. Sorry. My assistant. I let him go. My operation theater nurse, "Doctor, don't worry, I will help. Only thing is, I don't need air condition, I need cross ventilation because of the smell." Anesthetists were going in and out, that they were okay, but I can't leave the station. It took me 3 hours to clean the whole peritoneal cavity because it was full of fecal material and the pus. I don't know how patients survive. I gave him injection we call flagell. It's a very common metronidazole flagell injection, IV, very costly. After 10 days, patient walk off the hall. Miracle. Not me. Miracle. And he was not supposed to survive because he came with so toxic, so anemic, got blood transfusion, got operation, high dose antibiotic. So he was supposed to survive. No. Okay, that's my appendix. Appendicitis is very common in children also. Okay, so please remember right now, that's what it says, and it eventually perforate. That was happening in that case, if not treated. Please highlight the second one is called appendicitis is related to intraluminal obstruction. Make a note. The cause of most of the cases is intraluminal obstruction. Intraluminal obstruction with fecal leak. Normally, the fecal material go in and out of the appendix. They go into the appendix, they come out into the cecum. In some cases, the stool become impacted in the appendix, and that gives bacteria upper hand. They multiply because the fecal material is impacted over there, and they multiply, and that causes inflammation. That's what it says over here, hard pieces of stool within the appendix. This is the most common cause. Maybe gallstone, maybe tumor, maybe parasites and others, but that is the important cause. So it is related, appendicitis is related to please highlight, intraluminal obstruction of the appendix with fecal leak. We have types of diarrhea, the large volume diarrhea, small volume diarrhea. Now, manifestation of classic form of celiac disease. Celiac disease, now we call them gluten, please remember, make a note called gluten enteropathy. Celiac disease is also called gluten enteropathy. If I take gluten, it will create a problem for me. That's why nowadays, if you see it says gluten-free, gluten-free, gluten-free. Okay, so everybody's clear with that one? Celiac disease, sometimes, nowadays, very popular is gluten. I need to have gluten-free diet because I'm allergic to gluten. So, the patient with celiac disease usually present in infancy from very childhood, manifest as failure to thrive because the nutrition they're having, they are unable to absorb. That's why they're failure to thrive. The weight, they're not gaining weight. They're having diarrhea, abdominal distension. Occasionally, they do develop from severe malnutrition. So in these patients, they should have what type of diet?
Gluten-free.
Gluten-free diet. Sometimes those wheat, bread, they do contain gluten. So we need to be very careful whether that bread is gluten-free or not. Now, causes of constipation. Failure to respond to the urge to defecate. Very common. Number 2, inadequate fiber in the diet. If you folks remember, we should have, I said earlier, we should encourage have fiber in the diet. Maybe due to fluid intake, not enough fluid. Maybe weakness of the abdominal muscles. Too much muscles, fibers are replaced by the fat. That causes weakness of the abdominal muscles. Next is inactivity and the bed rest. Pregnancy in female, hemorrhoid. Now, because with constipation, it might lead to what we call fecal impaction. Stool become hard and they become impacted. I cannot defecate. I cannot go to the bathroom for defecation because I have some painful anorectal disease. Maybe some ulcer at the distal end of the anus is very painful. So in order to avoid from pain, I can go to the bathroom and the stool become impacted, hard stool. Okay, maybe due to some tumors or maybe due to some neurogenic disease which hamper the normal peristalsis. Use of constipating antacids and also bulk laxative. If you're taking laxative, have to have plenty of fluid. Next, or low residue diet, low fiber diet, low residue diet. Maybe drug induced. Last one was over here, prolonged bed rest and debility. And this one I said, after operation, after any major operation, we might develop obstruction also because of my prolonged bed rest, my bed rest after operation, or my condition of the body. Now, right over here, intestinal obstruction. Maybe mechanical, maybe paralytic or adynamic. Adynamic means, what is adynamic? Anybody can help me out? What is adynamic? Adynamic means there is no movement. No movement. no dynamo. Adynamic, there is no movement, and that is one of the type of obstruction. Obstruction results from neurogenic or muscular impairment of peristalsis. We call paralytic obstruction. Is it clear? It's called what? Paralytic obstruction. Next is we call mechanical obstruction. Can result from post-operative causes such as hernia, external hernia, or post-operative adhesion. So it's very important for after major surgery, they are more likely they can develop obstruction, or we should be very careful in giving water or any fluid right after operation. Okay. So the types of obstruction intestinal is, we already said, maybe mechanical or maybe paralytic. Mechanical will cause distension, and the paralytic because the loss of fluid and electrolyte imbalance. My dehydration or electrolyte imbalance that causes impaired movement that lead to paralytic obstruction. Please remember, right now the peritoneal cavity has a peritoneum. Inflammation of the peritoneum we call peritonitis. Okay. Now, peritonitis will occur. Look at those on the right column: perforated peptic ulcer, perforated appendicitis, perforated diverticulum. In late stage of gangrenous bowel or pelvic inflammatory disease. So those are the important causes for peritonitis. What it does, permit rapid absorption of bacterial toxin. Favors the dissemination of the contaminant. These are the normal function. If you look at on the left side, it's the normal function of the peritoneum. They're the normal job. Permit, what it does, peritoneum permits rapid absorption of bacterial toxin before it spreads. Now, favors the dissemination of contaminant. Number 3, it has a great inflammatory response. It forms a thick, fibrinous protective substance. And this peritoneum, within the peritoneal cavity, we call abdominal pulleys. Abdominal pulleys to control the spread of infection. If my appendix is inflamed, that peritoneal membrane will help to localize the infection in that particular site, prevent it from spreading. That's why we call peritoneum act as like, if you look at the normal, we call greater omentum, lesser omentum. Greater omentum is like a flap of peritoneum with 2 folds going down and cover the whole anterior wall, anterior surface of the abdominal content. And that peritoneum is acting as abdominal police. Is it clear? Help to localize the infection. And that's why sometimes you do use that peritoneum if there's any perforation. In order to repair the perforation, we do take the layer of peritoneum, put on the hole, on the perforation side, and then repair it. So important. We call peritoneal, I fix the perforation with peritoneal patch. Okay. Now, intestinal malabsorption. Now look at that. Failure to transport dietary constituents from the lumen of the intestine to the extracellular fluid. Absorption is not, normal absorption is not taking place. That's why I call failure. That is my malabsorption. Causes may be different causes, maybe celiac disease, inflammatory conditions, neoplasms, cancers, or colorectal cancers. The patient presents, these are the features they present. Sometimes they do have present with diarrhea. Please highlight steatorrhea. Steatorrhea. What is steatorrhea? Anybody? They do present with diarrhea. They do present with steatorrhea. No? Anybody? These patients with malabsorption, they do present that I have a bulk of stool in my toilet, and they are foul smell. Normal smell is there, but they have, on the top of the normal smell, they have a foul smell. And the stool is bulky. That is because I am losing the fat which I took in my diet. Nothing goes into my absorption, it's everything in my stool. Steatorrhea. Fatty, bulky, fatty, foul smell. Fatty, bulky, foul smell. Okay, so those are the presentation that may be bloating, abdominal pain, the cramps, weakness, muscle wasting, weight loss, and so forth. Now the colorectal cancers. Sometimes in family, sometimes with age. Patient who is suffering from chronic ulcerative conditions, condition of the large intestine and small intestine, we call Crohn's disease and ulcerative colitis. Sometimes they do have history of familial adenomatous polyposis. Sometimes depends on my diet. But most common is age and some family history, positive family history. In order to diagnose, we already said about the occurred blood test. We do check blood in the stool. We have to perform, we call digital, with gloves, put finger in the anal canal and go up all the way up to the, can't reach up to the rectum. So anal canal is almost 2 inches in length, and further it is my rectum. So digital rectal examination is the important again. By putting finger, we can diagnose a lot of conditions of the human body. My enlarged prostate, with the finger, I can diagnose. Patient is complaining of difficult urination. I put my finger in the patient rectal anal canal, and I can feel the prostate, enlarged prostate. Or I can, right now, for cancer, I need to find there is any polyp or not. Then, when we take the finger out, we need to see whether it is blood stain or not. Blood stain or not, fecal material with blood stain. I need to make everything in my note. Now, so the third is, next is we call X-ray studies using barium. We call barium enema. We do perform sigmoidoscopy after preparation and colonoscopy. sigmoidoscopy and colonoscopy. We do check the polyps, take the tissue out from that polyp, try to remove the polyp as much as possible, and do the biopsy. Oh. Okay. Any question from this part? Now, one thing is sometimes, look at the tube, small intestine or large intestine. Sometimes because of the chronic inflammation of those small intestine or large intestine, most common in small intestine, because small intestine is longer than the large intestine.
Excuse me, Professor? Sorry. Excuse me, Professor, but if he's in the waiting room still?
Yes, can you repeat, please?
Can you let Iffy in? He's in the waiting room still waiting.
I'm lost right now. You talking about the slide or you talking about my discussion?
No, I'm sorry. Iffy is in the waiting room waiting for you to let him in.
Oh, sorry. I'm sorry.
Sorry about that.
Thank you. Now, sometimes there is a chronic inflammation in intestine or sometimes the large intestine. And because of the inflammation of the tube, coil of the small intestine over here, coil of the small intestine over here, because the chronic inflammation over here, these two part of the small intestine, they are joined right now over here. Can you see this one? This part is a form, because of the inflammation, these two parts become connected. Because of the chronic inflammation on this part of the small intestine and chronic inflammation on this part of the intestine. They become connected and they forms a passage of the fecal material, food material, whatever. And this passage, which is formed because of my chronic condition, that is called fistula. Spelling is okay? No? Yes? You need spelling? F-I-S-T-U-L-A. Fistula. They did my barium extra, barium enema. They said, not only you have all those ulcers, you also have fistula. We need to fix that fistula also. We need to repair that fistula. Fistula is a tube-like passage. It's a tube-like passage which developed because of my inflammatory conditions of my small intestine or large intestine. Sometimes this fistula develop because of developmental defect. Not only due to inflammation, chronic inflammation. Sometimes we do born with those fistula. Everybody is clear with that one. I said not only inflammatory, sometimes we born with those fistula, but defect. My esophagus, my trachea are connected. Esophagus in the neck and the trachea in the neck, they are connected. Birth defect. When these newborn, they're present with bubble in the mouth. Bubbles in the mouth. This is not okay in this newborn. He should not have those air bubbles in the mouth. That means the trachea is connected with my esophagus. That is also a fistula. You folks have diagram in the textbook also. Okay. on page 10, on page 1078. Is it clear? Page 1078, there's a diagram. That is congenital fistula by birth fistula. Now, sometimes, this is my small intestine, coil of small intestine, one part of small intestine is invaginating into the other part. Look at this one. This is small, this whole tube, small intestine. One part of small intestine going into the other. That is called what? Anybody? More common in children. And they have in this textbook also. Anybody? No, it's called
Intussusception.
Very good. Can you repeat again, please?
Intussusception.
Very good. That's the one I'm talking about. Intussusception. One part of the small intestine going, invaginating or telescoping into the other part. Patient, children, mostly present with bloody diarrhea, abdominal pain, and the lump. We need to cut, remove that part, and anastomose. Very common. Intussusception. Okay. So don't forget, please remember in your prayer, intussusception and fistula also, which was not in the PowerPoint over. Okay. Chapter 38. And over here, please remember the normal anatomy of this whole hepatobiliary system. You have to know the liver, location of the liver, lobes of the liver, the structure within the liver. We call hepatic lobule, if you folks remember. And if you understand that one, you will know what is going on during pathology. You have to, but before, you have to know the normal anatomy and function of these structures: liver, gallbladder, pancreas, and plus make sure the tubes which are coming out from my liver, we call right and left hepatic duct, they join to form the common hepatic duct. This common hepatic duct join with the cystic duct to form common bile duct. And this common bile duct join with the pancreatic duct, and these two ducts together open into my second part of the duodenum. That's how bile is coming, enzymes are coming. Pancreas is what type of gland? Is it endocrine or exocrine?
Exocrine? Oh.
Both. Pancreas is a mixed type of gland. It has endocrine part and exocrine part. Okay. And also, I think they have unfolded. So let's meet time to time. I will interrupt. So this is over here. The liver is the largest visceral organ in the body. Weighing approximately almost 3 pounds in weight in adult. It is located below the diaphragm and occupies much of the right hypochondrium. part of the left lobe of the liver, extended to my epigastric region also. Now the liver is anatomically divided into two large lobes, right lobe and the left lobe. And there are two small lobes we call caudate lobe and quadrate lobe. Make sure you know the location of those small lobes of caudate and quadrate. Now, liver, blood flow, and accessory organ. For the blood supply of the liver is receiving the hepatic portal vein. From where? From the digestive tract and major abdominal organ like my spleen, like my pancreas. Spleen and pancreas contribute for the portal vein. How portal vein is formed? How portal vein is hepatic portal vein or deep portal vein is formed? How are you going to form these hepatic portal vein or the portal vein or deep portal vein? I can call by different names, but same structure. What are the two vessels we join to form the portal vein? Anybody? I already said two vessels. Please remember, we call, look at my hand, this one and this one. This is my splenic vein, splenic vein coming from the spleen, and this is my superior mesenteric vein. Superior mesenteric vein and the splenic vein, they join together to form, this is my portal. Is it clear? What are those two vessels? I said splenic vein, and the superior mesenteric vein. Superior mesenteric vein, they draw the blood from the small intestine, part of the large intestine. So the superior mesenteric vein, splenic vein join to form the portal vein. And this portal vein drains the blood. What type of blood the portal vein has? What type of blood they have? Portal vein blood? What type of blood they carry?
Oxygenated.
Oxygenated? No. Then the other choice is deoxygenated, of course. It is a deoxygenated blood. Please remember, it is a deoxygenated blood and the nutrient-rich blood. It is a deoxygenated and nutrient-rich blood because they are coming from my small intestine. Because they are draining, superior mesenteric vein drains small intestine. So all the nutrients are absorbed in the small intestine. Okay. Now we do have hepatic artery. Hepatic artery is a branch of abdominal aorta. Please remember. So hepatic artery, which arises from the abdominal aorta, of course, that hepatic artery blood is oxygenated. Portal vein blood is deoxygenated, but they are nutrient rich. Now, we do have hepatic vein. Hepatic vein is coming out from the liver, and this hepatic vein drains blood into the inferior vena cava. Please remember, all these are very basic things. So hepatic veins, these are valveless veins that empty into the inferior vena cava. Where this inferior vena cava is going? Where this inferior vena cava blood is going?
To the heart.
Which part of the heart?
Right.
Right side of the heart. Very good. Right side of the heart. Inferior vena cava, superior vena cava, inferior vena cava, coronary sinus. Okay, so please remember for the liver, those blood vessels very important. Now the gallbladder, and we are dealing over here the exocrine part of the pancreas. We are not dealing endocrine part because pancreas itself has two components, exocrine and endocrine. Okay. Functions of the liver and pancreas. Liver and pancreas produces digestive enzymes such as a secretion. These are normal functions of the liver. It synthesizes glucose, plasma proteins, and blood clotting factors. Look at the functions of the liver. They're not only metabolizing glucose, carbohydrate, protein, they're also synthesizing plasma protein and clotting factors. What are the plasma proteins? Anybody? Plasma proteins. Okay, and? Fibrinogen. Okay, anything else? Something in the middle, in between.
The one.
Globulin, albumin, globulin, fibrinogen. These are the plasma proteins. Most abundant is my albumin. Okay. Now, the liver, the metabolism of carbohydrates, protein, and fat. Liver is responsible for the degradation and elimination of drugs and hormones. Now the endocrine pancreas, over here, insulin and glucagon needed in cell metabolism, alpha cell and beta cell. What insulin does? Insulin. What is the function of insulin?
Regulates blood sugar.
How? It lower the after any meal or whatever, when the blood sugar is high, insulin is coming from the pancreas, and they help to lower the blood glucose, push all those glucose from the blood into the cell. If the cell doesn't need those glucose, insulin help to convert those glucose into what?
Glucagon.
Glucagon. No, glycogen.
Glycogen.
Glycogen. So surplus glucose, which is not needed at that moment, that surplus glucose is converted into glycogen. Please remember, there are two sources of glycogen. One is where? Where we store glycogen? Liver and muscle. Those two areas, skeletal muscles and the liver. Glucagon, on the other hand, help to raise the blood glucose. This is normal. Glucagon help to increase the blood glucose when the blood glucose is way down. I'm suffering from right now hypoglycemia. I skip my lunch. Blood glucose way down. Glucagon coming from the pancreas. It will go straight into the liver and the skeletal muscle. Break down all those glycogen into glucose, push them into my blood. Bring my blood glucose back to normal. That is glucagon. Okay, so please remember the functions of the liver: production of bile salt, elimination of bilirubin. Please remember how bilirubin is coming into existence. Breakdown of old RBC, lead to formation of heme and globin. Please remember, and heme is converted into bilirubin. Next is the metabolism of steroid hormone. Liver helps in the metabolism of drugs. Okay. So this is normal metabolism of carbohydrate, fat metabolism, protein metabolism, storage of minerals and vitamins, filtration of blood, and the removal of bacteria. Who does this one? Filtration of blood and removal of bacteria from the liver.
The kidney?
What liver have? What cell is performing this last function, removal of bacteria or old RBC or deformed RBC? Anybody? We do have in the liver. There's some cell in the liver, they eat those products like bacteria.
Macrogens?
Pardon?
Macrogens? Or macrophages?
I can't.
Macrophages?
They're doing the job of macrophage, but they do have specific names. It's called Kupffer cells. Make a note. Kupffer cells.
How do you spell that?
Kupffer. Kupffer cells. Kupffer cells, these are the type of macrophage. Their job is to clean those products. Clean those products from the blood. Because the portal vein, when they're coming from the small intestine, they are not only carrying nutrition, they also carry the waste products. And those waste products need to be handled. And that Kupffer cells within the liver before they send back into the hepatic vein. Is it clear? That is the Kupffer cell. Please remember. Oh, so the last one over here. Okay. Okay, jaundice. Causes of jaundice. Number one, excessive destruction of red blood cell. So what happened then? It says excessive destruction of the red blood cell. How jaundice will happen over here? Look at the pathology.
Accumulation of bilirubin.
Okay, yes. That old RBC, when the RBC undergo destruction, they release those heme and globin. Heme, which is converted into iron, and biliverdin and bilirubin. Liver has some limit. If it goes up beyond the limit of the liver, that bilirubin accumulates in the body tissues, and that causes jaundice. Liver says, I can handle only 100 pieces of bilirubin. If you give me 200, I won't. I will keep in my body tissue, and that gives my white color of the eye, light color of the skin, yellowish change. That is jaundice. Normally, bilirubin is coming out in my urine. Normally, bilirubin is coming out in my stool. That gives my stool a brown color. My urine is straw color. Okay. So, number two is impaired uptake of bilirubin by the liver cell. Liver has the capacity, that's what I said. Number three, decreased conjugation of the bilirubin. When those bilirubin is coming out, coming from the macrophages, we call free bilirubin, which is insoluble in the plasma. In the liver, those free bilirubin are going into the liver for conjugation, to make that conjugated bilirubin water soluble so they can flow in my fluid of my plasma. Or, last one over here, obstruction of the bile flow in the canaliculi of the hepatic globules. May be intrahepatic, within the liver, or outside the liver. Those tubes blocked, either within the liver or outside the liver. Outside the liver means extrahepatic means they're talking about the bile duct, right and left hepatic duct, common bile duct. They're talking about the hepatic duct, common bile duct. Now, all are important. Categories of jaundice. One over here is called pre-hepatic. Pre-hepatic means liver is okay, my ducts are okay, but something is happening within the vascular system that causes pre-hepatic jaundice. So please remember the major cause is excessive highlight, excessive hemolysis of the red blood cell, excessive breakdown or hemolysis of RBC. And that result in bilirubin, we call unconjugated bilirubin, blood level goes high. We call hemolytic. This is called prehepatic. Make a note over there. We call what jaundice? Hemolytic jaundice. Hemolytic. That means breakdown of what?
Hemo.
RBC. Hemolytic jaundice causes because of excessive breakdown of RBC that lead to jaundice that is called hemolytic jaundice. Is it clear? Now, intrahepatic. That is something wrong within the liver itself. It's caused by disorder that directly affect the ability of the liver to remove bilirubin from the blood or fail to conjugate it so it can be eliminated in the body. And that is, in the PowerPoint it says conjugated bilirubin, but in intrahepatic jaundice we do see both conjugated and unconjugated bilirubin goes higher than normal. Now, the last one over here, the post-hepatic. That means something wrong. Liver is perfectly fine. Liver is working okay, but there's something is wrong with my tube, which is coming out from the liver. Those tubes are called what? Tubes, what are those tubes? Those tubes we call duct. Right hepatic duct and the left hepatic duct. Okay, so post-hepatic is if those duct, right hepatic duct or the left hepatic duct become obstructed or blocked, that causes post-hepatic jaundice. Occurs when the bile flow is obstructed between the liver and the intestine. Please remember those duct. Those are important. Which of the following is not the cause of jaundice? Excessive destruction of the red blood cell, we just mentioned. Impaired uptake of bilirubin by the liver cell, we just mentioned. Ingestion of iron, I don't think so. Decreased conjugation of bilirubin, yes. Obstruction of the bile flow, yes.
C.
Yes, so iron has no relationship with the jaundice. But we do need iron for what? Why we need iron? What? Pardon?
Carry oxygen.
Okay, before carry oxygen, so who need that iron?
Hemoglobin.
Hemoglobin. For the synthesis of hemoglobin, we do need iron. Without iron, we cannot have hemoglobin functional. So each hemoglobin contains 4 iron, and each iron contains 1 oxygen. That's why we said earlier, I don't know if folks remember now, each hemoglobin carries 4 oxygen. Each hemoglobin carries 4 oxygen because each hemoglobin has 4 iron. And each of these iron binds with 1 oxygen. So that is taken care. Okay. Bile flow, liver bile. That's the secretion from the liver by the liver cell we call hepatocytes. So liver produces approximately 500 to 600 ml of bile, which is yellowish green color per day. Now, cholestasis represents a decrease in the bile flow through the intrahepatic canaliculi and reduction in the secretion of water that causes cholestasis, obstruction in the bile flow, bilirubin and bile acids by the hepatocytes. So all those lead to, normally we produce almost 500, 600 ml of bile per day. If the body doesn't need that bile is stored in where? Where we store bile? Gallbladder. So gallbladder stores the bile, and what gallbladder does? Only storage? Concentrate. So the gallbladder not only store the bile, gallbladder also concentrate my bile. Please remember right now, these are the assessment of liver function. These are the tests we do use. Number one, serum amino transferase level. We do have in the textbook also, please go from the textbook also, all these liver function assessment. Assess the injury to the liver. So if the enzymes are above normal, so that means indicates something is wrong, is not going well with my liver. Number two, bilirubin, normal serum bilirubin, we need to see that one. GTT and alkaline phosphatase, ALT, SGPT, SGOT used to be called SGPT and SGOT. We do perform ultrasonogram, CT scan, MRI. Now, also, we do see the vascular pattern within the liver by means of angiography. We do perform liver biopsy, used to obtain tissue specimen for microscopic examination. Now, I went to my doctor and I gave history of discomfort in the right hypochondriac region and also loss of appetite, low-grade fever, and stool is altered stool, and they said, we're going to do your biopsy. It looks like you have some, we did X-ray, we did CT, looks like your liver has some tumor. So we need to check tumor, is good tumor or bad tumor. So they did biopsy of my liver tumor. Now, the nursing staff need to be careful. For what? After my biopsy, I'm in the hospital, they said we need to watch you 24 hours and check for any bleeding because they are working on my liver. Because clotting factors, because my liver disease, clotting factor is not there. Look at that, clotting factor is not, the liver is not producing normal clotting factor. They used to produce because my liver condition clotting factor is not there. Now they did my biopsy. Doctor said we're going to keep your eyes, we'll keep you for observation, mostly to check whether you are having any bleeding or not. If no bleeding, we'll discharge you. But we need to watch because you're most likely candidate for bleeding. Is it clear? Yes or no? Everybody understand that? Okay. That comes with liver biopsy as a bonus. Okay. Okay. Pathologic conditions affecting the hepatobiliary system. So please remember the network of hepatobiliary system. My liver, those duct, the gallbladder, that cystic duct, pancreas with pancreatic duct. Okay. Injury from drugs and toxin. Infections, inflammations, or immune responses. Maybe metabolic or maybe some neoplasm. That all these conditions might affect my hepatobiliary system. In the textbook, they have reaction phase 1, phase 2, and phase 3. Phase 3 over here, they discuss in the form of biotransformation. My question is, can we feel normal liver in the patient? Can we feel it? No. Why no? Answer is correct. Why no?
Because it's within the rib cage?
Pardon?
Because it's within the rib cage, like,
Very good. Because the inferior margin of the liver and the costal margin. That's why when I feel with my hand or palpate with my finger, we're not supposed to feel the inferior border of the liver. If the liver is enlarged, I can feel my costal margin, I can feel the inferior margin of the liver. And then we need to make a note that on liver palpation, the liver is 2 finger enlarged, 2 finger from the costal margin. I need to make a note. So whoever sees that patient, that this doctor, when inspect during palpation of the liver, he found 2 finger, 3 finger, whatever finger. Now after a month of treatment, the liver is regressing, going back to normal. That is also it has to be the note. It is 1 finger, 2 finger, whatever, and then no palpation, you can feel the inferior margin. So normally we can feel because inferior margin of the liver corresponds with my costal rib, costal margin, not costal rib, costal margin. Okay. Host factors okay. Folks, let's take a break a little bit. Returning time is 11:45. After the break, we'll take care of this one. 11 folks on Zoom, we are taking break. Returning time is 11:45. Okay, folks, so let's get back. Okay, before we start, I'm going to miss you guys who are here right now in person. But don't miss me. Make sure you're on the Zoom. Okay? And I'm going to see next week my other half of the family. So, about the final exam, if school can make arrangement for 60 students in this space, I will let you folks know. If not, I will make an announcement how we're going to have the final exam, because the number of students is the factor. Okay, so don't miss me. Please make me happy by working hard. That's the only thing you can make me happy.
I have a question, Professor. Is the final going to be cumulative?
Cumulative final.
Are we going to have a review?
All those, if you keep the study guide, all those questions, whatever you have, that one is nothing new. Everything repeat. But you have to know the basic thing. Okay, let's start.
Professor, on the syllabus, it says it's only on the last 2 chapters.
Last?
The final, it says that it's only on the last 2 chapters. It doesn't say cumulative.
Whatever we're discussing, everything will be in the final.
All right.
Okay. What chapters we want to discuss? Okay. The slide over here, and please pay attention to the discussion over here. We are not done for the day. It says host factors contributing to susceptibility to drug-induced liver disease. Maybe we are genetically predisposed, we are susceptible. Maybe my age causes liver-induced injury, or we do have underlying chronic liver disease, or my diet, or the alcohol consumption. Sometimes the drugs, some medications are toxic to the liver. We have to know whether it is toxic to the liver or kidney or not. Those are very important. Now, the drug-induced liver diseases, number one is direct hepatotoxic injury. Some people they do, some people they don't. We call idiosyncratic reactions. Sometimes it's called cholestatic reactions, which causes obstruction the flow of bile, or suffering from chronic hepatitis. Causes of hepatitis, it is the inflammation of the liver that is called hepatitis. Maybe autoimmune disorders, most common is the viral. Now, reaction to drugs and toxins might cause hepatitis. Infectious disorders like malaria, which is not, we are good, we don't have in the West Coast, we do have in the East Coast. Malaria, infectious mononucleosis, salmonellosis, and amoebiasis. It is also common in the South America, which is very common. Malaria is very common. Now, hepatotrophic viruses, which is important, that primarily affect the liver cells or hepatocytes. Virus which affect my liver cells. They can cause direct cellular injury and induction of immune responses against the viral antigens. These are all viruses, A, B, C, D, C, and please remember, hepatitis A, hepatitis B, hepatitis B associated, hepatitis C, and hepatitis E. So please remember A, B, and C. Hepatitis A, which is spread from person to person by fecal oral route. Contaminated food, contaminated water, or infected food, infected water. But the good thing about hepatitis A is we do have vaccine. We can prevent if you're going some places where hepatitis A is endemic. You can have vaccine before you go over there. And also a good part of hepatitis A is it doesn't go into chronic state. We recover from hepatitis A completely. But the drawback is once you have this hepatitis, you cannot donate the blood. Blood donation becomes no. So good thing is we can recover. Good thing is vaccine is there. Now hepatitis B virus, it is spread from person to person. How? By contaminated blood or the tissue fluid. Person to person. Maybe my blood has hepatitis B virus. Maybe my semen has B virus. Maybe my saliva has B virus. Maybe my wounds, secretion from the wound has B virus. And similarly, hepatitis C virus also spread in the same manner. We can prevent hepatitis B by vaccination. But if you have this hepatitis B virus, once you have it, you're getting vaccine, no cure. No cure for hepatitis B and also the C. But you can prevent before it happens by vaccination. As now, hepatitis B vaccine is mandatory also. And this hepatitis B virus can go into chronic, can cause cirrhosis of the liver, or can cause carcinoma of the liver. Liver can turn into cancer or turn into fibrous tissue. So please go with A, B, and C. Now, varying factors of hepatotropic viruses, mode of transmission, and incubation period. Hepatitis B virus has the long, not hepatitis B virus. AIDS virus has the longest incubation period, followed by hepatitis B virus in terms of incubation period. Now, the mechanism, degree, and chronicity of the liver damage, ability to evolve to a carrier state, that is mostly because maybe B virus and C virus will go into lifelong carrier state or turn into cirrhosis or turn into cancer. Is the following statement true or false? Hepatitis is caused by viral insertion to the host cells. True or false? Insertion into the host cells genome resulting in death of the cells. Now, if you look at this one, some forms of hepatitis are caused by viruses, but not all. Not all. Like autoimmune, like drug-induced, like fatty liver because of my fat or because of my alcohol. So, but overall, viral infections is a common cause for hepatitis. Sometimes it's drug-induced, sometimes now dietary habit called fatty liver, or because of a drinking habit, may cause direct cellular injury or induction of immune responses against the viral antigen. Now, alcohol-induced is important that causes fatty liver. liver disease can be caused by fatty liver, can be alcohol induced, and lead to cirrhosis. This is a late effect of alcohol. And that's how the metabolism is going on with alcohol. Now, the primary cause of intrahepatic biliary disease may be primary sclerosing type, and the secondary. Most common is secondary also. Early symptoms and late symptoms. Early symptoms, we do suffer from unexplained pruritus, itching, weight loss, fatigue, or loss of appetite. Sometimes people used to smoke, some people used to smoke, now they don't have the taste for smoke. I don't like to smoke. Something going on in my body. Now later symptoms, dark urine and pale stool. And now becomes obvious on my body, on my skin.
Professor, we can't hear you. Professor?
The Zoom? Yes. You folks can hear me now?
Yes.
Yes.
Thank you. Make my day. Okay, so let's move on to cirrhosis. We said it is the, please remember cirrhosis, it is the fibrous replacement of my normal hepatic tissue. When they turn into fibrous tissue, the liver cell loses its normal function. For metabolism, whatever the normal function is gone. Now, how these patients are presenting with cirrhosis. Please remember, they may present with weight loss, anorexia, weakness, diarrhea, or constipation, enlarged liver, jaundice, abdominal pain. These are all common features of hepatobiliary system. Please highlight portal hypertension. This is the effect of cirrhosis, and I'm having portal hypertension. Increased pressure in the portal vein. Increased pressure in the portal vein, that is we call portal hypertension. Patient with cirrhosis, they present with enlarged abdominal cavity enlarged, because within the abdominal cavity, my peritoneal cavity is filled with fluid. Peritoneal fluid. Normally we have peritoneal fluid, but it becomes so much, it causes distension, obvious distension, and that is called ascites. Please remember. Now, sometimes the patient also present with esophageal varices. Hematemesis, remember hematemesis, blood stain vomiting. So highlight hematemesis. Sorry, not hematemesis, sorry. Esophageal varices. Esophageal varices is increased pressure in the esophageal vein. That in some cases might rupture, and that gives me as a present symptoms of hematemesis. Blood stain vomiting. Sometimes spleen becomes enlarged also. So please, portal hypertension, ascites, esophageal varices. Now, if there's something going on with the liver, that will resolve all these factors. If you do those sites, like hematologic disorders will occur, maybe anemia, leukopenia, thrombocytopenia, everything. Endocrine disorders, skin disorders. Then in the textbook, I believe they do have some pictures of this patient also. And then hepatorenal syndrome. And the last one is called hepatic encephalopathy. Because of the liver disease, the patient is losing his consciousness. Please remember, hepatic encephalopathy. In order to take care of this patient, we need to watch these patients' blood ammonia level, very important. Ammonia is toxic, and because the liver cannot metabolize ammonia, normally ammonia is converted into urea with the help of liver. And this urea will be getting rid of urea with the help of kidney. Look at that one. Liver is supposed to metabolize my ammonia, but I'm suffering from liver disease. That ammonia is supposed to convert into urea, and this urea is supposed to get out from my body with the help of kidney. So build up blood level ammonia is the important factor. So whoever taking care of this patient with hepatic encephalopathy, they need to increase the neurological assessment of this patient, whether the patient is deteriorating or staying stable or getting better. Neurological assessment of these patients are important. Can you hear me? Can you hear me? Look at that one. I said, hear me. Normal. Can you hear me? or I press patient deeply, check the response. So that is neurological assessment of these patients are important. If my blood ammonia is going higher and higher and higher. So key factor is I need to increase the frequency of neurological assessment. That's the important. I'm not going to, we need to save this patient. Okay, so that is taking care with hepatic encephalopathy, with ammonia, the neurological assessment frequency increase. Portal hypertension. Normally, this patient with portal hypertension, they do also have present with fluid. Normally, we do have fluid, peritoneal fluid, increase in the volume of fluid in the peritoneal cavity, that is myositis. Esophageal varices happens, sometimes spleens are enlarged also. How we manage, how we treat this patient, treatment of liver failure. Eliminating alcohol intake when the condition is caused by alcoholic cirrhosis. We need to know what is caused. If the medication is the food, preventing infections, preventing sufficient carbohydrate, providing sufficient carbohydrate and calories to prevent the protein breakdown. Because if I'm starving, my protein undergo breakdown. My protein breakdown turn into ammonia, and ammonia is already toxic. Correcting fluid and electrolyte imbalances. Decreasing ammonia production. Look at this one. Decreasing ammonia production in the GI tract by controlling protein intake. When we starve, when we are not taking food, when we are starving, protein breakdown, muscle protein breakdown. And that protein creates problem because it's converted into ammonia. So liver transplant progress is not good. Okay. Liver cancer, primary liver cancer, hepatocellular carcinoma arises from the liver cells, cholangiocarcinoma, primary cancers of the bile duct cells. Okay. Okay, folks, before I touch this gallbladder, please remember, I think it's click my head over here. Please remember, in some cases, I'm in a different topic right now. So I'm not talking about gallbladder. I'm not talking about the liver. Thing is, right now, sometimes in some cases, stomach can herniate through the esophageal opening of the diaphragm. That is called what hernia? Anybody? Pardon? Sometimes because of my diaphragm has an opening for the esophagus, and through that opening of the esophagus, stomach can herniate into the thoracic cavity. This is called hiatal hernia. Please remember. Hiatal hernia.
Can you spell it?
Hiatal. Hiatal hernia. Patient present because stomach is going in and out through that esophageal opening. That is called hiatal hernia. We do have hernias various types. We have, which is not part of this. Sometimes the children, they do herniate through the umbilical opening. I don't know you folks know or not. That's called what hernia? Umbilical hernia. Umbilical hernia, which is also common. Part of the small intestine is coming out through the umbilical opening. It's called umbilical hernia. Okay, so let's get back to the gallbladder now. Now the gallbladder, we already said what gallbladder is doing. Please remember the normal function, location, and others. Normal anatomy. Definition, it is a distensible, pear-shaped muscular sac located on the ventral surface of the liver. Okay. The layers, we have mainly 3 layers. Outer serous, which is my peritoneal, which is my peritoneal layer, followed by smooth muscle layer, followed by innermost is my mucosal layer. This mucosal layer is continuous with the lining of my duct. Bile duct, I mean bile duct over here. First of all, we need to know this lining continues with the cystic duct and later on the common bile duct. Because the cystic duct is the duct which is coming out from the gallbladder. Cystic duct is the duct which connects the gallbladder, not the bile duct. Okay. Function, store and concentrate bile. Storage of bile, concentration of the bile. Now, components of hepatobiliary system. Gallbladder. Then we do have right and left hepatic duct. This right and left hepatic duct come together to form the common hepatic duct. Look at the diagram and retain those information. Then the cystic duct extend to the gallbladder. Then question of CBD. C, make an abbreviation, CBD, common bile duct. Formed by the union of or joining of the common hepatic duct and the cystic duct. Cystic duct and the common hepatic duct, they join to form the common bile duct. And this common bile duct, further down, behind the pancreas, behind the second part of the duodenum and the pancreas, they join the pancreatic duct to open into the duodenum. Now the gallbladder and the formation of gallstone. Entrance of food. Now how this gallbladder is working. Whenever we do have fatty food in the small intestine, they release hormone we call, if you folks remember, we call CCK, cholecystokinin. And that cholecystokinin causes contraction of the gallbladder to release bile. Now, so look at the PowerPoint, it says entrance of food in the small intestine causes the gallbladder to contract and the sphincter of the bile duct to relax such that the bile stored in the gallbladder moves into the duodenum with the help of hormone cholecystokinin, CCK, cholecystokinin. The two primary factors contribute to the formation of gallstones are, number one, abnormalities in the composition of the bile, and number two, the stasis of the bile. Composition of the bile, maybe increase in cholesterol, decrease in water, or stasis of bile flow, traffic jam, and that causes gallstone formation. Cholesterol which is coming out in the bile, it is the waste product. So the formation of cholesterol stone is associated with obesity. We do have stone in the gallbladder we call cholelithiasis. Cholelithiasis. The stone within the And inflammation of the gallbladder, this highlights called cholecystitis. Cholecystitis is the inflammation of the gallbladder only. Inflammation of the common bile duct, we call cholangitis. Inflammation of the tube or duct, called cholangitis. This gallbladder disease is common in female. Gallstone is common in female also. Now, pancreatic secretions contains proteolytic enzymes that break down dietary protein. Pancreas produce various type of digestive enzymes. Secretions include pancreatic amylase. Pancreatic amylase, we do also produce the same type of amylase from the saliva. We call salivary amylase. And this is called pancreatic amylase. That means it's coming from the pancreas. What it does, it breaks down the starch into monosaccharides and disaccharides, and the lipases, which hydrolyzes the neutral fat into glycerol and fatty acid. Lipases for fat and amylase for carbohydrate. Pancreatic enzymes are secreted in the inactive form and become activated in the intestine. Of course, with the help of enzymes in the lining of the small intestine. Common causes of acute pancreatitis. These are the causes, please remember. Number one is gallstone, stone in the common bile duct, alcohol abuse, or hyperlipidemia. My blood lipid, everything is above normal. My HDL level, my LDL level, my triglyceride level, all are above normal. Hyperparathyroidism, increased parathyroid hormone causes stone. Infections after abdominal surgery, and some steroid and thiazide diuretics. Okay, so forms, they are chronic pancreatitis, pancreatic cancer. It's very painful. Pancreatitis, because and the problem is with the pancreas is we cannot detect the pancreas early because of its location. It is deeply behind the stomach, below the stomach, behind the stomach. We cannot palpate until unless it becomes severe and the patient is present with the symptoms. And by that time, it's too late. So the cause of pancreatic cancer is unknown. The smoking appears to be a major factor. The second most factor appears to be diet. Okay. Which of the following organs is directly responsible for the elements of cholelithiasis?
Gallbladder?
Gallbladder. Liver, sorry. Direct response, because the liver is causing stasis. Because the cholesterol is coming in surplus. Liver is exporting the cholesterol which is surplus for the body, which is not needed, and that causes formation of stone. Oh, okay. And I went to the ER and I was having persistent, I went to the ER, I was having persistent vomiting and throwing up. On admission, They start my IV drip because I might be dehydrated. And they put some tube through my nose. That is called what tube? NG tube, nasogastric or nasogastric suction. They put NG tube. I was still in the hospital, I was throwing up, and the nurses were sucking through the tube. They sucked so much, and then they didn't replace the IV fluid according to my body. And as a result of NG suction, they are getting the acid out, hydrochloric acid out from my stomach, and my body is developing a condition of metabolism we call metabolic alkalosis. Why? Because they keep sucking my NG through the NG tube, my gastric juice. Gastric juice has acid. We need a balance between acid and base. They suck so much, and they put my body in metabolic alkalosis. So we need to replace that electrolyte to be correct. We need to correct those alkaline condition by some sort of hydrogens and others. Did I forget anything? So many things. And also, folks, please remember those chronic condition of the large intestine, Crohn's disease, ulcerative colitis I mentioned, celiac disease, for the jaundice, for the hepatobiliary system, please know the normal anatomy. First of all, if you know the normal anatomy, you can handle any question. I think we are pretty much done. So I already said what we are going to do for the final. I don't have any confirmation yet about the final. So if something comes up, I will definitely announce on Canvas. And also, today is the fifth exam 5th, is that correct? On that basis, I need to make a decision. I need to start emailing those students who really need help. They know, all the students, you folks know your number. And depending on this fifth percentage, what makes the final so far, and on that basis, I will email the students. So help yourself if you need. The best thing is study in group, small group. Maybe I studied last night the whole chapter. When next morning I came and started discussing, everything was down the drain. What I read last night, when I start discussion, was not correct. Whatever she's answering is in the book. What I'm answering is not there. That's how I study myself in group of three students. Whenever we studied, no personal talk, no talk outside the book. Everything in from the book. That's the point. Otherwise, some student, this is my whole thing with experience. Some students, they study at home, they are done. When they come for study, discussing, they want to waste the time, kill the time. That is sometimes the student's nature sometimes. So this human nature, oh, I'm done, let me relax. So kill his or her time. Is it clear? So please study small. know what is coming up. So you guys are going for the medical field, you need to help the patient, you need to, just your responsibility, a lot of responsibility. Okay, I'll see you folks. Take care, make sure, maintain, everything is still, the mask is there. Okay. Thank you. Thank you, folks.
Have a good
You
weekend.
too, thank you.
That would be nice. Yeah, I'm like right here. Oh, I just need that, like, I still have a couple more quizzes to like.
Thank you, everybody.
Thank you.
So it's gonna beat me or break me. Yeah, that's what I do.
As hard as it is. See you next
I'll
week.
see you.
All right.